Hi everyone. I wanted to spend a few minutes on budgets. So the basic financial document used in most organizations is the budget, which is a detailed financial plan for carrying out the activities an organization wants to accomplish for a certain period. A budget is stated in terms of dollars and includes proposed revenues, so monies received for providing goods and services, and expenditures, money spent on goods and services. The budgeting process is an ongoing activity in which plans are made and revenues and expenditures are managed. The management functions of planning and control are tied together through the budgeting process. A budget requires that nurse leaders establish their program goals and expectations. Healthcare organizations use different types of interrelated budgets. The major budgets discussed in this sections are going to be the operating budget and the capital budget. So the operating budget. The operating budget is the financial plan for the day-to-day activities of the organization. The expected revenues and expenditures generated from daily operations given a specific volume of patients are stated within it. Preparing and monitoring the operating budget, particularly the expenditure portion, can be a time-consuming a time-consuming job. The expenditure part of the operating budget consists of a labor budget and a supply and expense budget for each cost center. A cost center is an organizational unit for which costs can be identified and managed. The labor budget is the largest part of the operating budget for most nursing units. Before the labor budget can be established, the volume of work predicted for the budget period must be calculated. A unit of service, which is a measure of the work being produced by the organization, is used. Units of service may be, for example, patient days, clinic or home visits, hours of service, admissions, deliveries, or treatments. Another factor needed to calculate the workload is the patient acuity mixed. The formula for calculating the workload or the required patient care hours for inpatient units is as follows. The workload volume equals the hours of care per patient day times the number of patient days. Workload. The workload is either established by the financial office and given to the nurse manager or calculated by nurse managers who forecast the volumes. Forecasts usually start with a baseline of the last year's actual workload statistics and predict whether the volume in the upcoming year will be higher or lower. Nurse managers should inform administration about any factors that might affect the accuracy of the forecast, such as changes in physician practice patterns, new treatment modalities, or changes in inpatient versus outpatient treatment practices. The next step in preparing the labor budget is to determine how many staff members will be needed to provide care. Because some people work full-time and others work part-time, full-time equivalents, or FTEs, are used in this step rather than positions. Generally, one FTE equals to working 37.5 hours per week, 52 weeks per year, for a total of 1950 hours of work paid per year. And so typically when you are paid as a nurse working full-time, it will be 1950 hours per year. 1/2 of an FTE, or a 0.5 equivalent, equates to 18.75 hours per week. The 19.5 hours paid to an FTE, so to a full-time equivalent, in a year consists both of productive hours and non-productive hours. Productive hours are paid time that is worked. Non-productive hours are paid time that is not worked, such as vacations, statutory holidays, orientation, education, and sick leave. Before the number of FTEs needed for the workload can be calculated, the number of productive hours per FTE is determined by subtracting the total number of non-productive hours per FTE from total paid hours. So this is just giving you an example of workload classifications. So patient acuity, you've got patient acuity level 1 to 5. So 1 would be low patient acuity, 5 would be high patient acuity. Hours paid per day, hours of care per day, is the number of hours of care on average for a given acuity level. 1 patient per 1 day equals 1 patient day. So it goes up for patient hours, and then that equals the workload, the total number of hours of care needed based on the acuity level and the number of patient days. So you can see, yeah, I'm just going to leave it at that. So next is the supply and expense budget. The supply and expense budget includes a variety of items used in daily unit activities, such as medical and office supplies, minor equipment, books and journals. It also includes orientation, training, and travel. Each expense category generally has its own budget line and expense code. Although different methods are used to calculate the supply and expense budget, usually the previous year's expenses are used as a baseline. Ideally, this baseline is adjusted for projected patient volume and specific circumstances known to affect expenses, such as predictable staff turnover, which increases orientation and training expenses. A percentage factor would be added in to adjust for inflation. However, the reality in many Canadian jurisdictions is that budgets rarely grow as quickly as actual expenses, and managers are expected to find efficiencies to arrive at a balanced budget. And so this is the issue. The revenue budget. The final component of the operating budget is the revenue budget, which projects the revenue from a variety of sources that the organization will receive for providing patient care. Historically, nurses have not been directly involved in developing the revenue budget. Anticipated revenues are calculated according to the specifics of the nursing area or program. Data about the volume and types of patients and funding are necessary to project revenues in any healthcare organization. Even when nurse managers do not participate in developing the revenue budget, learning about the organization's revenue base is essential for good decision making. Lastly, the capital budget. The capital budget reflects expenses related to the purchase of major capital items such as equipment and physical plant. So physical things that you need to buy for the whole hospital. A capital expenditure must have a useful life of more than 1 year and exceed a cost level specified by the provincial or territorial government. The minimal cost requirement for capital items in healthcare organizations is usually from $2,000 to $5,000, although some organizations have different levels. Anything below that minimum is considered a routine operating cost. And so you need to build in these capital expenditures as a nurse manager into your forecasted budget. So any new equipment that you want to buy. The phases in the budgeting process are similar in most healthcare organizations, although the budgeting period, budget timetable, and level of manager and employee participation vary. Budgeting is done annually and in relation to the organization's fiscal year. A fiscal year exists for financial purposes and can begin at any point on the calendar, but is generally from April 1st to March 31st. The major phases in the process include gathering information and planning, developing unit and departmental budgets, negotiating and revising, and later using feedback to evaluate budget results and improve plans. Each healthcare organization develops a timetable with specific dates for implementing the budgeting process. The timetable may be anywhere from 3 to 9 months. At a minimum, nurse managers are responsible for meeting the fiscal goals related to the personnel and the supply and expenses part of the operations budget for their unit of operation. Typically, monthly expense reports of operations are sent to nurse managers who then investigate and explain the underlying cause of variances greater than 5%. Many factors can cause budget variances, including unexpected changes in patient census or patient acuity, vacation or sick time, and staffing levels or mix. To accurately interpret budget variances, nurse managers need reliable data about these factors. Nurse managers can control some, but not all of the factors that cause variances. After the causes of variances are determined and if they are controllable by the nurse manager, steps are taken to prevent the variance from occurring in the future. However, even uncontrollable variances that increase expenses might require actions by nurse managers. For example, if supply costs rise drastically because a new technology is being used, the nurse manager might have to look for other areas where the budget can be cut. And you can imagine what the nurse managers are going through right now with the increased costs related to COVID. Productivity is the ratio of outputs to inputs, which can be written as output/input. In nursing, outputs are nursing services as measured by hours of care, number of home visits, and so forth. The inputs are the resources used to provide the services, such as personnel hours and supplies. Productivity can be increased by decreasing the inputs or increasing the outputs. Hospitals often use hours per day per patient, so HPPD, as a measure of productivity. For example, if the standard of care in a critical care unit is 12 HPPD, then 360 hours of care are required for 30 patients for one day. When 320 hours of care are provided, the productivity rating is 113%. So it's 360 plus 320 equals 1.13, which means either productivity increased or needed care was not delivered. One must consider the quality component in any productivity model related to care. Staff nurse and budgets. Why do staff nurses need to understand the budget? Although they are not directly accountable for the budget, staff nurses play an important role in meeting budget expectations. Many nurse managers find that routinely sharing the unit's budget and budget monitoring activities with staff nurses fosters an appreciation of the relationship between cost and the mission to deliver high patient quality care. Having access to cost and utilization data allows staff nurses to identify patterns and participate in selecting appropriate, cost-effective practice options that work for both staff and patients. Nurse managers and staff nurses who work in partnership to understand that cost versus care is the dilemma to manage rather than a problem to solve will develop innovative, cost-conscious nursing practices that produce good outcomes for patients, nurses, and the organization. So in conclusion, nursing services are a major cost component of healthcare delivery. Nurse staffing and scheduling are critical in maintaining effective healthcare services. Staffing is an integral part of effectively managing delivery costs. All nurses play a role in meeting budgetary expectations.